Hello and welcome back to Inflammation Station. As always, my name is Dr. Scott Paskowitz. I am your co-host along with Dr. Sanjay Gadwani. Welcome. How are you today?
I'm doing fantastic, man. How you doing?
I'm doing great. You know, I'm just excited about this podcast because really we talk about education and collaboration, not just for our patients, but for other providers and the community at large. And I know you and I are very passionate about that. I know you do a lot of speaking in the community, give of your time, but we have a really interesting case for you today. And that's really what we want to talk about today is this case of this person who had a diagnosis of psoriatic arthritis. And she was a bit resistant to medication recommendations that you made. And you know, what happened was she came in one day in a lot of pain. And she had elbow pain. She had it right here. And it was a little bit unique of a spot. We mentioned lateral epicondylitis last time, or tennis elbow, but this was a little bit lower down, kind of in no man's land. There's no tendons there. There's no real big ligaments. So I got out my ultrasound machine and I get in there, and lo and behold, we see, and you can see it up on the screen, this white kind of hook. And it was really this kind of bony outgrowth of the bone. And the patient was really surprised. One, she was relieved because, you know, she didn't know what it was, but now you can literally see what's causing your pain.
Right.
Now, the nice thing about ultrasound is that the patient sees it, you can move through it and see the movement. And also too, I'm looking at it and I press on it with the head and I'm like, is that your pain? And she's like, yeah, that's my pain. So it was really eye-opening to her. Now, there's another aspect to this with medication and her resistance to some medication. So tell me what happened next. I kicked this back to you. We showed you the film, and take it from there.
So, you know, this is a good teaching point for everyone, right? It's a good education point. There's a lot of key scenarios in this. First is the diagnosis, then it's the management, and then more importantly, it's the hesitation to treat, right? For the side effects, right? So like a little bit about psoriatic arthritis, it's a complicated disease, right? It's a very systemic disease, and there's multiple key components to it, right? So one of the key things we need to understand about psoriatic arthritis is that it's got a lot of domains, right? You highlighted a good point about the elbow and the tendons, and that's one of the hallmarks of the disease. Is enthesitis, inflammation of the tendons. That's one of the classic hallmarks of spondyloarthritis and psoriatic arthritis, and we don't see that in other diseases, right? There's obviously the skin involvement that you talked about with the psoriasis. There's nail involvement, pitting of the nails, and disruption of the nail beds with psoriatic arthritis. There's also ocular diseases like uveitis that can occur with this disease. Now, one thing to understand about this particular patient is that she presented more with peripheral symptoms, meaning elbows or joints that are not necessarily central or axial. So actually psoriatic arthritis is divided up. You can have axial symptoms. So a lot of patients may have low back pain and stiffness, and especially in the morning, sitting down. And then we're going to talk a little bit about mechanical and inflammatory back pain in a little bit.
Well, it is inflammation station, so we have to get the inflammation.
We got to get the inflammation out, right? So it can be axial, it could be in your spine, lower hips, and classically it can affect like deep into the buttocks in your sacroiliac joint.
Yeah, that SI joint,
The SI joint, and that's kind of like where your spine connects to your hips, all right, your pelvis. So there's little ways of identifying this disease. But one of the things you also mentioned is the bony overgrowth.
Like
the bones.
See it a lot in the ultrasounds, especially in the elbow area.
And that's actually another hallmark of the disease, and that is new bone formation. You will not see that in diseases like rheumatoid arthritis or lupus or other autoimmune diseases, where in spondyloarthritis, psoriatic arthritis, you will see new bone growth. This can happen in your ankles, like where the Achilles insert, you may see like an Achilles enthesophyte enthesitis, which is unleft treated. in the elbows, but classically you can also see it in your spine. And in the spine, they're called syndesmophytes, like bridging osteophytes. And this would not happen in osteoarthritis, these particular classic findings that you see on x-rays and imaging. So that's a really important part of the disease, and just educating people that, yes, you can get new bone formation with spondyloarthritis and psoriatic arthritis. Yeah.
Now, let me ask you a question. This is my own information, and probably out there has maybe same questions.
Yeah.
Spondyloarthropathy or spondyloarthritis, there's a whole host of diseases that fall under that.
Yeah.
And I believe colitis and Crohn's as well.
Correct.
In psoriatic arthritis, we do see the enthesophytes. Do we also see those in Crohn's and colitis? Do all spondyloarthropathies show that?
Yeah, so also, like, great question, right? So the key thing to understand is pretend like spondyloarthritis is this umbrella term, right? It's a big umbrella term, and each little spokes on the umbrella are a different disease. So in spondyloarthritis, classically, we have ankylosing spondylitis. We have psoriatic arthritis.
That's that like bamboo spine, right?
Yep. We have IBD-related arthritis, reactive arthritis, anterior uveitis, so multiple different diseases. And actually, there's a newer disease or diagnosis, which is like the precursor to this, right? And it's called non-radiographic axial spondyloarthritis.
That's a mouthful.
It's a mouthful. NR-AXSPA, right?
Okay, I like the abbreviation better.
Non-radiographic axial spondyloarthritis. And this is before the damage has occurred, right? So patients, there's an actual delay of diagnosis for someone to be diagnosed with psoriatic arthritis and spondyloarthritis for almost 7 years, Scott.
So they have this disease for 7 years and they're undiagnosed on average. That's amazing.
Average diagnosis. And this is where that collaboration and that education really comes in, because these symptoms are going to be intermittent, periodic, flares, we'll call them, right? Doc, I feel really good. And then all of a sudden my elbow blew up, my ankle blew up. I felt I was doing great. And all of a sudden I couldn't get out of bed. Yeah. So these things linger. Typically they're younger, middle-aged patients. But like they come and go, they migrate. Shoulder, ankle, elbow, knee. So like just the whole characteristics of this disease, delaying diagnosis. I saw this one for this one. I saw this doctor for that. But ultimately, it can become debilitating.
Yeah, and I know as a physical therapist, and any physical therapist watching out there, I know I've seen this a lot in the clinic now that I do the ultrasounds on, the autoimmune crowd. Bilateral plantar fasciitis. That can happen in these spondyloarthropathies, right?
Yeah, unilateral or bilateral can occur. Classically, if you have the sacroiliitis bilaterally, like we are likely going to be leaning towards more ankylosing spondylitis. Psoriatic arthritis can be unilateral in the sacroiliitis, unilateral, and it can be any joint, right?
Yeah, anything.
Like if I'm looking at my hand, like rheumatoid will affect the whole knuckle. Like it would affect all of these knuckles.
Loves to affect those
MCPs.
Middle,
the middle joints, your
PIPs,
your PIPs, but it will never affect the DIPs, right? Your distal joints. So rheumatoid arthritis never affects this. This is mainly osteoarthritis, but psoriatic arthritis could be one tip, any tip.
Yeah.
It could be one joint, any joint. It could be one whole hand, like the whole finger, and that's another hallmark when the whole finger. And that's termed dactylitis or sausage digit, which is also another hallmark of
They don't
this
like
disease.
that term. They don't like
They don't like that term.
Yeah, but it fits it. It does look like a sausage.
And then sometimes the dactylitis is confused for gout.
Right.
Like the patient goes to the ER and like my toe is swollen. Oh, they're like, it's gout.
Right.
But it's actually dactylitis, and it's psoriatic arthritis is the correct diagnosis. So like, again, this is the detective, the digging, the history, the talking to providers and getting what the real complaints are from the patient.
You got to really think whole body holistically when you're dealing with diseases. And I love the mindset of the rheumatologist, because they are treating and thinking about the whole body, not just that one little joint at the end there, you know.
Yeah.
So what turned in from this little joint could be diagnosed as this larger disease. So
treat patients, not numbers, not imaging. Treat patients, listen to their pain, hear them, feel them, understand them, what their day-to-day is like, what their activities are like. Sometimes it's like, oh, I can't hug my kids in the morning. I have a hard time buttoning my shirt because my hands are so swollen. Like, just really empathizing with them.
Now let's get back to this patient, right? So she came in, she had a diagnosis of psoriatic arthritis. She came in a lot of pain. We saw this bony protuberance, and that was a real eye-opener for her. She had been a little resistant to certain medications. So when you saw her, tell us what happened after that in the treatment, and her openness to more disease modification.
The way I'd like to approach this, right, and this in every patient, every encounter, it's about you, right? It's about that patient.
Yeah.
A lot of times people ask me, well, what do you do with patients with this disease? I'm like, I don't know. I do something different every single time.
Yep.
I do something different. Everybody is different.
You're definitely not cookie cutter when it comes to
there's no cookie cutting in rheumatology.
No.
Right? Everything is a spectrum. Everybody's at a different stage.
Yeah.
So there's no what happens with every single scenario. So this particular patient, like many, right? Like, they're hesitant on medication treatments. Everyone's worried about side effects. Like, the key thing that I really try to explain is a diagnosis, right? One, and first and foremost, patients want to know what is wrong with me. Why do I feel this way? Right? And when we get to a diagnosis, so the first visit or so, we're working it up, we're doing imaging, ultrasounds, blood tests, whatever the case may be. We gather the information and we present it. And listen, if your clinical story, your results match a diagnosis and you have active symptoms, you have active disease. So the first step is accepting the diagnosis.
Yeah.
Right? Like, listen, you have psoriatic arthritis. Do you know that you have? This is the reason why you have been feeling this way.
Yeah.
Right? Now let's do something about it, right? So the first part is just being aware, learning about it, accepting it, and then moving forward.
Yeah.
I always give something to someone, maybe anti-inflammatories or steroids, to show them how they can feel.
Yeah.
Right? Prednisone is not forever. We'll probably do a whole talk on prednisone.
Definitely need to.
And anti-inflammatories, we'll do a whole talk on that too. And everything in between. But prednisone, anti-inflammatories, oh doc, when I take 2 Aleve twice a day, I feel amazing. Well, you can't take Aleve forever, right?
Yeah.
Everything has its pros and cons, right? So the first step is accepting. The second step is making them aware of what they should feel like. Like, this is what you should feel like. When you're 32 years old, you shouldn't wake up and be stiff for an hour every day. Like, your hands shouldn't swell every morning, right? This is just not normal.
And what's amazing is that becomes people's new normal.
Yes.
Right? So,
correct.
It's like, oh, I just thought this is the way everybody felt, because it gradually creeps up on you and you think that's your normal, when it's really not. So, yeah.
Yeah, so just letting them know what they could feel like and getting to that acceptance. And then, fear is an illusion, right? Like, everyone's worried about side effects. Of course, look, the internet is a great tool, Google, so on and so forth. They're great resources, but there's too much sometimes.
Yeah.
And then, sometimes the mind plays tricks on you and you start going down a negative path. Right? Like, we can all use it to our education, but we shouldn't also hinder our care.
Yeah.
Right? Like, I don't feel well. Can I take this medication? And side effects, I tell everybody, side effects are like car accidents, right? People drive every day, right? Hundreds of millions of people drive every day. There's thousands and thousands of car crashes every day, accidents. And some accidents are severe. Some accidents are severe. They can cause injuries. They can cause fatalities. Yeah. But side effects are exactly the same, right? Like, what is the likelihood that this is going to happen to you? What is the likelihood of this rare, severe, very nominal occurrence happening, right? Like, what is the incident? But people still drive every day. People still do. People still fly every day, right? So don't let the fear of something stop you from improving your health. Because I know today it may seem scary, right? But if you leave something untreated, like, what's going to happen in 5 years? What's going to happen in 10 years, right? Like, what are my joints going to look like in 10 years?
Yeah,
right?
We know 100% of the time, left untreated, what these diseases look like.
Yeah.
And, a lot of times patients, and I did the same thing. My wife has Crohn's disease. We did the same thing. We worried about that small percentage of side effects, but we weren't as worried about the disease. Now, 2 surgeries later, we're finally on board with, let's treat this disease correctly. And my heart goes out to patients that, we know, I know Dr. Ogadwani can help you, but they just don't, but they worry about the side effect. But, we can't make anybody do anything. We can only recommend and do our best to educate, collaborate.
Yeah.
And so this patient, let's close this up. How did this patient do once she?
So, I think time, right? You have to give patients time when they're ready, willing, and able to, right? So I gave her options and I said, look, it's time to try something. And the key is I convinced her to try a disease-modifying agent. I convinced her to say, let's give this 3 to 6 months.
Yeah.
Just give me 6 months. If you feel better, great. If something goes wrong, you have any kind of adverse reaction, listen, I'm not gonna leave you on something that doesn't suit you. All this medicine's making me sick. No, you gotta take it. No, you don't. Because there's other options.
There's a lot of other options out there.
And Scott, you did mention something, and I want to take a minute to discuss this, right? Like, we know what these diseases are going to do.
Yeah.
Listen, if this was 20, 30 years ago, we didn't have these medications.
It's amazing the progress in this field of medicine.
Unreal.
Yeah.
Unreal.
Amazing.
Like the boom in technology and medication and science, halting bone erosions.
Yeah.
Halting permanent joint damage, irreversible joint damage. When you talk to older rheumatologists, they'll say, well, everybody walked into my office looking like this. Everybody was in wheelchairs.
Yeah, we don't see that anymore.
We just don't see it.
Because if that happens, someone didn't do their job.
Someone didn't do their job.
Yeah, either on the patient end or on they just didn't get diagnosed.
Yeah, so like there is that patient-physician relationship. There is that patient-physician trust, right? Which we cannot supplement with Google. We just can't do it, right? We need to understand how you feel, what you're willing and able to try. I don't want to take this. I don't want to take this. Okay, but can you try this instead, right? So there's that give and take.
Yep. There's
that rationality. There's that agreement that we're gonna try something. So we eventually went on to treat her, and she started responding. And the key thing about these medications, the disease-modifying drugs, they're not prednisone, like they're not anti-inflammatories, right? They take a little time to work. But listen, these diseases did not start overnight. You didn't wake up one day and it was like, oh my God, I have lupus and psoriatic arthritis. It took you almost 7 years to diagnose it, right? So it's going to take a little bit of time for the medications to work.
Yep.
Give it a couple of months. Let's see, and we monitor, right? I told her, I said, listen, we're going to monitor everything.
Yeah.
I'm going to check your blood tests, your kidney, your blood counts, your liver. I'm going to check everything. I'm going to see you. And a great part of rheumatology is that.
Yep.
I'm going to see you in a couple of months.
Yep.
I'll see you in 8 weeks, 2 months, 3 months, whatever it is.
Yeah.
And it's that relationship building that I love, right? It's not like, oh, you got a UTI, here's some antibiotics, I probably won't see you again.
Yeah.
Right? I'm going to see you, and I'll see you soon. But if you need me, call me sooner.
Yeah.
And it builds that relationship, which is like one of the great things about rheumatology.
Yeah, that is, we do get to see patients along a lifetime. Speaking of follow-up, I do want to see her and re-ultrasound that elbow, and I want to see if that bony outgrowth goes away on this medication.
Sounds good.
Yeah, I want to see that.
Yeah.
So anyway, that concludes our episode. Thank you for listening. Go to our Facebook page, Island Rheumatology. Inflammation Station. Go on our websites, islandrheumatology.com, inflammationstation.org. Like us, share us, watch us on the podcast, and you guys have a great day, and thanks for tuning in.